Preoperative evaluation for pulmonary surgery. The common procedures which are performed in pulmonary or thoracic surgery are pneumonectomy, lobectomy, wedge resection, and segmentectomy. So, in order to proceed to surgery, we need to confirm the diagnosis, see the indications of surgery, fitness, and comorbidities, including cardiopulmonary reserve, risk stratification, and if malignant tumor is present, resectability and operability should be assessed. Resectability, which indicates that the tumor can be completely excised of the clear margins, RO resected possible, and operability, which indicates that the tumor is resectable with acceptable risk of death or morbidity of the patient. So the basic patient demographic should be considered: occupational exposure including asbestos, berylliosis, farmers, lungs, silicosis, aspergillosis. Assessment of the symptoms including dyspnea, cough, chest wall pain, hemoptysis, hoarseness, fever, weight loss, night sweats, symptoms suggestive of metastatic disease such as new onset of headache, focal neurological symptoms, new seizure disorder, fracture, and new bone pain. Symptoms linked to paraneoplastic syndrome such as central obesity, Cushing syndrome, bone pain, hypercalcemia, and confusion syndrome of SIADH should be considered. Functional capacity of the patient including performance status, risk factors of coronary artery disease, past medical history of systemic disease and previous tumors including chemotherapy and radiotherapy, past surgical history including the resection of tumors and cardiothoracic procedures, history of general anesthesia and associated complications, medication history and allergies including perioperative warfarin and platelet therapy, substance misuse such as tobacco smoking, alcohol and other drug usage, family history of early chronic obstructive pulmonary disease which may be suggestive of alpha antitrypsin 1 deficiency, respiratory infections at a younger age which may be suggestive of cystic fibrosis, and pulmonary nodules with telangiectasia which may be suggestive of Osler-Weber-Rendos disease. So performance status, various scoring systems can be used to define the functional performance status including the Karnofsky's performance status, Eastern European Oncology Group performance status, and ECOG WHO Zubrod system is most commonly used, which include 0 asymptomatic, fully active, able to carry out the all pre-disease activities without restriction. Symptoms: number 1 is symptomatic, completely ambulatory. Number 2 is symptomatic with less than 50% of waking hours in bed during the day. Number 3 is symptomatic with more than 50% of waking hours in the bed. 4 bedbound, completely disabled. 5 is the dead patient. The MRC dyspnea score including 0 dyspnea on strenuous exercise, 1 dyspnea on walking up straight hill, number 2 dyspnea on walking on the level ground, number 3 must stop breathlessness after 100 yards, number 4 cannot leave the house breathless or dressing and undressing. The important features of clinical examination is the general examination, inspection of the patient and palpation of the patient and auscultation of the patient. In general examination, the overall comfort of the patient plus rate rhythm of the respiration should be noted. Evaluation of the nicotine stains, cyanosis, clubbing, intrathoracic malignancy and ptosis, meiosis, pallor, telangiectasia, raised jugular venous pressure, movement of the cervical spine and presence of cervical lymphadenopathy. Inspection of the spinal deformities such as kyphosis or scoliosis, shape of the chest, barrel shape, pectus deformity, volume loss, movement of respiration, detailed veins, scars, and brains and swelling. Small mouth opening, as it will hamper the double lumen intubation. Palpation should include the position of the trachea, chest expansion, tactile vocal firmitus, increased tactile vocal firmitus, such as in pneumonia, and percussion should be carried out resonant percussion in normal hyperresonant pneumothorax, dull percussion, pleural thickening, stony dull percussion, pleural effusion. Auscultation shows vesicular breathing, normal bronchial breath sound with consolidation, reduced air entry, wheeze like in COPD and asthma, crackles, left ventricular failure, pleural rub, asbestosis, chest wall tumors, pulmonary embolism, pneumonia, pleurisy, and post-surgery. And in auscultation, the heart murmurs, valvular heart disease, S3, pulmonary hypertension, like P2, muffled heart sound, abdomen, look for the scars, hepatomegaly, and palpable masses, central nervous system, and focal neurological deficits. Investigations include full blood count, coagulation profile, liver function test, chest radiograph, CT scan, and PET scan, MRI scan, and in some cases barium or gastrograph in solo. For pulmonary function testing, spirometry, gas transfer studies, arterial blood gases, ventilation perfusion scintigraphy, cardiopulmonary exercise testing, shuttle walk, and 6-minute walks test, and stairs climbing, which we'll be discussing later. So mortality rates in pneumonectomy 6.8%, bilobectomy 4%, lobectomy 3.9%, lesser resection 1.4%. So preoperative evaluation need assessment of the patient in disease process and operation. So first is fitness for the surgery. We see age, pulmonary function, cardiovascular fitness, weight loss, performance status, and nutrition. Then we assess the operability, the diagnosis and staging, operability and adjuvant therapy, operations available, locally advanced disease. For fitness of the surgery, age, pulmonary function testing, cardiovascular fitness, and weight loss, performance status, and nutrition should be evaluated. Age. The advancing age increases the risk surgery for clinical stage 1 and 2 in patients over 70% of age is equal to younger patients. Age over 80 years alone is not a contraindication to lobectomy or wedge resection. Pneumonectomy is associated with higher mortality rates in elderly. Pulmonary function testing. Pre-op lung function is important. Arterial blood gases, spirometry analysis should be done. So, spirometry, the force expiratory volume 1, FEV1, force vital capacity, and maximal volume ventilation are most commonly used measurement for the assessment prior to thoracic surgery. A low MVV is a non-specific but very useful in estimating the capacity of the patient prior to the major lung resection. Estimation of the predicted postoperative FEV1 is used for the risk stratification of the patient. Arterial blood gases analysis on the room air provides important information of PaO2 and PaCO2 levels. Low PaO2 levels are not contraindication to pulmonary resection since the abnormal lung can be resected and may be contributing factor. The high resting PaCO2 levels increases the postoperative morbidity and mortality, but it is not an absolute contraindication to proceed with surgery. Gas transfer studies. The diffusing capacity of the lung for carbon monoxide estimates the diffusion of carbon monoxide across the alveolar capillary membrane and reflects the functional surface area of the lung. A low DLCO is independent predictor of the postoperative morbidity and mortality. Estimation of predicted postoperative DLCO is therefore routinely used for the risk stratification of patients undergoing a lung resection. Postoperative lung resection, postoperative FEV1 of PPO DLCO, quantitative ventilation perfusion scan, quantitative CT scan, and cardiopulmonary exercise testing, and shuttle walk testing. Ventilation perfusion scan is performed to estimate the number of functioning segments and therefore perfect postoperative lung function, but only a significant ventilation perfusion mismatch is suspected. Result from the scan may estimate the actual postoperative function. Cardiopulmonary exercise testing is a core diagnostic test to assess the patient's cardiopulmonary reserve in measuring VO2 maximum oxygen consumption, and can simultaneously assess the subject's cardiac and respiratory and skeletal muscle function. Lower levels of VO2 max are associated with increased morbidity after pulmonary resection. It is generally performed for functional assessment in patients with moderate to high risk of postoperative dyspnea using VO2 max greater than 15 mg per minute is a cutoff for good function due to the heterogeneity of the studies. However, it is difficult to extrapolate of the cutoff for prohibitive resection. CPEX is associated with high cost and it is not readily available in all centers. The shuttle walk testing, the patient is asked to walk shuttles around two cones placed around 9 meters apart, so to cover 110 meter distance whilst walking across the cones for each shuttle. The pulse and oxygen saturation should be monitored during the exercise. A distance walked of around more than 100 meters is considered the cutoff for good function. 6-minute walk test. This is the measure of the distance patient can walk quickly on flat, hard surface for 6 minutes. It is easier to administer, better tolerated, and measurement of pulse oximetry can be added to record the significant desaturation. The study had demonstrated better surgical outcomes in patients with good performance status at 6-minute walk test. Stair climbing is a symptom of limited stair climbing. Exercise can be performed with pulse rate and oxygen saturation measured using a portable pulse oximeter to detect the desaturation using the exercise. The maximum altitude reached during the stairs climb exercise and desaturations of more than 4% are independent predictors of postoperative complication. So we perform the AVG PCO2 of more than 50, traditional contraindication for lung resection, PO2 less than 90, spirometer FEV1 of more than 0.6 liter for segmentectomy, more than 1.5 liter for lobectomy, and FEV1 of more than 2 liters for pneumonectomy. DLCO less than 60% predicted associated with increased mortality. PPO FEV1 of more than 40%, PPO DLCO of more than 40%, and SaO2 of more than 90% have average risk. PPO FEV1 of less than 40% and DLCO of less than 40% have high risk. So we can calculate it by pre-op FEV1 into 19 minus segments to be removed divided by 19. So quantitative ventilation perfusion scan. It is highly accurate. Inhaled 133 xenon or technetium 99 IV. Normally 19 segments, 10 right and 9 left. So we have on the right 3, 2 and 5, 55%, on the left 3, 2 and 4, 45%. The guidelines for the selection of patients undergoing pulmonary resection for lung cancer can be used to determine the risk of dyspnea following surgery. FEV1 and DLCO should be obtained in all the patients prior to lung resection. Patients with post-operative predictive FEV1 or DLCO less than 40% are at a moderate risk of post-operative dyspnea, where preoperative functional assessment is moderate or poor, and where the patient have heterogeneous upper zone emphysema in settings of upper and lower lobe. Criteria of the lung volume reduction surgery should be considered. As post-operative lung function might improve in these patients, suspected post-operative predictive values below 40%. Segment counting is utilized to predict the post-operative lung function. The additional benefit of information obtained in the split lung function testing is unclear. PQ scan, quantitative CT scanning, and perfusion MRI is utilized in high-risk cases to demonstrate a non-functioning areas prior to resection. 6-minute walk and shuttle walk test, stair climbing, and cardiopulmonary exercise testing can be used as a functional assessment in the risk stratification of the patient prior to lung resection. The guidelines recommend that shuttle walk distance of more than 400 meters or cardiopulmonary exercise testing VO max more than 15 per kg per minute may be considered as a cutoff for the good function. Shuttle walk is the best distance in 2 shuttle walks. Desaturation of the test of more than 4 liters of SaO2, stair climbings and walking tests. They climb 3 stairs of stairs is good for lobectomy, 5 stairs is good for pneumonectomy. VO max less than 15 ml per kg per minute indicate that patient is high risk for surgery. In the cardiovascular assessment, the goal of the cardiovascular risk assessment is to identify the patient with active cardiac disease. History of assessment of functional status, physical examination, ECG are absolute prerequisite for patient undergoing the thoracic surgery. All patients with an audible murmur or unexplained dyspnea should have a cardiac function assessed with an echocardiogram. If an active cardiac condition is present, the assessment by the cardiologist and the preoperative correction is recommended. Like unstable coronary syndromes, decompensated heart failure, significant arrhythmias, severe heart disease. If no active cardiac conditions are present, the revised cardiac risk index should be used. Like good functional status less than 2 risk factors, surgery should be offered. Poor functional status more than 3 risk factors, cardiology opinion should be sought. The risk of cardiac death or non-fatal MIs associated with lung resection is 1 to 5%. The revised cardiac index have 6 variables which include high-risk surgery, include all thoracic surgery, history of ischemic heart disease, history of congestive cardiac failure, history of CVA or TIA, insulin-dependent diabetes, and serum creatinine of more than 177. The risk of major cardiac complications like MI and pulmonary edema or cardiac arrest or complete heart block increases proportional to the number of risk factors. So cardiac risk factors could be major, intermediate or minor. Weight loss, performance status and nutrition should be assessed in every patient. Operability, so one has to do the diagnosis and staging, operability and adjuvant therapy and the options available. Diagnosis of and staging include history and physical examination, chest x-ray, CT, CBC, platelets, chemistry, smoking cessation, pulmonary function testing and bronchoscopy. And one has to see the cancer staging of the lung. Stage 1A disease, PFT, bronchoscopy, mediastinoscopy, EBUS, PET scanning. And stage 1B, 1, 2, 2B, PFT, bronchoscopy, mediastinoscopy, PET scanning, brain MRI. Stage 3B, stage 3A, PFT, bronchoscopy, mediastinoscopy, brain MRI, MRI of spine, PET and CT scan. So PFT, bronchoscope, CT scan in all the patient, mediastinoscope all except T1 and MRI brain stage 2B, T3 invasion. Testing of the preoperative lung function is designed to eliminate the patient's assessment and see if they are fit for surgery. Patients who are smokers and have pulmonary disease increases the risk of surgical complications. If there is a chronic lung disease or the risk of pneumonia and respiratory failure is higher, and if the patient is a smoker, the high risk of lung complication. If the patient is obese, there is a high risk of lung compilation in elderly and over 60%. Over the age of 60, we get risk of atelectasis. The other thing that increases the risk of complications is the duration of the surgery. If the general anesthetic is for long duration, like more than 3 hours, increases the risk that comes back to the physiology, which causes the collapse of the lung, more stress on the lung. The surgical site also increases the advancing age can increase the risk of atelectasis. Is the closing capacity. The concept of closing capacity is that the patient has elderly, when breathe in and out, the alveoli should not normally collapse. So the intrinsic property of the lung is to keep them open. So they need to have a good functional capacity to keep the alveoli open before the surgery. So if the normal tidal breathing, the patient who are old, they don't have the capacity to keep the alveoli open, and this is one of the reasons why we do blood gas preoperatively, and if the blood gas is less than normal in the older patient and they have atelectasis and can lead to shunting in the lungs, and that is the one reason why the patient are prone to get atelectasis during thoracotomy and lung resections, and these patients have higher risk of complication, and we need to be more careful in elderly patients. And obesity reduces the functional residual capacity because it pushes on the lung, especially when the patient are supine, which lead to collapse. It also increases the work of breathing and feel weak after having anesthetics and after prolonged anesthetic, especially if they have hypoventilation, and there are more chances of getting pulmonary embolus. So avoidance of smoking and obesity is important. The functional capacity is important. So we will discuss about the functional capacity of the patients. Functional capacity can be used for the cardiac as well as respiratory functional capacity, and it's a good indicator to assess the patient for the surgery. Normal oxygen consumption is 250 mils per minute, which can be assessed by the physiological assessment of the patient. Patients with cardiac and respiratory disease have reduced number of METs. For cardiac patient, more than 4 METs are okay, and less than 4 METs are a high risk. 4 to 5 9 METs are okay, and greater than 9 are MET risk. And for the respiratory, it has a similar number. Three-pronged or three-legged approach is assessed for the respiratory mechanics and gas exchange and functional capacity, or also cardiopulmonary reserve. Respiratory mechanics, lung expanding and inhalation exhalation and getting oxygen into the lung. Gas exchange is getting into the alveoli, from the alveoli to the tissues, that is cardiopulmonary reserve or the functional capacity, and depends on the cardiac capacity to shift that oxygen. The cardiopulmonary reserve testing the heart or the lung is normal, also gives a global index of something that is right or not right. Functional capacity is one of the important three things of all those assessments. So we are looking at the test results in a patient who comes to you, and one has to be a great surgeon to operate on the low functional reserves. So if you see them walk, if the functional capacity is good, then the high chances they may survive the surgery. Most common test used is the walk test, that basically measures how patient can walk in the 6 minutes on the flat surface. It should be a flat surface, and they can walk as far as they can in 6 minutes. So it gives a global response to the exercise, and usually they compare the distance to the normal age and compare it to the control. So it should be age matched according to the male and the female. Normally it's around 600 to 700 meters. If they desaturate for more than 6%, that's not a good sign. Gold standard is around 600. It's a functional test, and it's easy to use, and see how much they can walk. And the formal testing is VO2 max, which is the oxygen consumption in kilograms per minute. This is the gold standard. Functional capacity testing or cardiopulmonary, and you need a full exercise laboratories, exercise bicycle or treadmill, and they need to breathe in the mouth and see the how much they breathe, and it's very expensive, and we can't do it everywhere. But when you do a formal VO2 max, 15 mils per kilogram per minute is considered good. If patient can achieve more than 15 per kg per minute, they have decreased mortality. If it is decreased than 10, they have higher mortality. So 15 is comparable to 600 meters walk. So it's similar to the cardiac stress test that we do for assessment of the cardiac stress function. So 6-minute walks test is comparable to 15 minutes per kg VO max. So if we are testing for the asthma, we need to test after they have taken the asthmatic medications, because on the day of the surgery we have to give their Ventolin in asthmatic patients, or if the patient has COPD, then they have to treat accordingly. So if it is less than 10, it's an absolute contraindication to do the surgery. If they can't achieve 10, we don't let them operate. If 600 meters walk test is not again, then you can go for stairs test, and stairs test is important. Spirometry, or the pulmonary function testing, is very simple bedside test if we have the equipment to do it. Big hospitals will have a laboratory, and they have testing which is more accurate, and there are small places where we don't have these investigation. So what we do is ask the patient to blow into the machine, and we measure the forced vital capacity breath. In DLCO, we need more specific thing. This is just the recap of terms from the physiology. So this is the total lung capacity, which is around 5 volume. Tidal volume is the breathing we do when we are resting, breathe in and out. Functional residual capacity, what's remaining in the lung at the normal lung. The vital capacity is breathe and empty out our lung as much as we can. What's left in the lung is called as residual volume, and this is the expiratory reserve value. In chronic lung disease with emphysema, residual volume increases, functional residual capacity increases. In pulmonary fibrosis, the decrease. That affects the test results. FEV1 is expressed in liver, and results are given as an absolute value as a percentage predicted compared to the age, sex, height, and match control. So there are actual tables, we can use it. In general, FEV1 of more than 3 liters man is normal and 2 liters in woman is normal. FEV1 falls in COPD and less than 50% predicted indicative of severe disease. If more than 1 liter absolute is equal to very severe disease. PEFR used for asthma is normally more than 200 mils per minute. So FEV1 FVC ratio is normally 0.7 to 1. FVC increases in COPD and decreases in restrictive lung disease. FEV1 FVC of less than 0.7 in obstructive lung disease and greater than 0.7 in normal or restrictive lung disease. Patient with asthma or emphysema may get some improvement with FEV1 with bronchodilators. So the patient who have poor FEV1, we take bronchodilators, then it will improve. And then repeat the tests. Bronchodilators can help the patient with emphysema. They work more in asthma. So if we talk of subsegments, there are 20 subsegments on the left and 12 on the right. It is good to have a rough idea. So on the right there is a middle lobe, on the left there is no middle lobe. It's important the surgeon assess segmentectomy or subsegmentectomy or lobectomy. If somebody is doing left upper lobectomy, you leave 10 segments. If doing right, you leave 6 segments. So the concept of the predicted post-operative values should be assessed accurately. So if the patient has a lung taken off, what do you predict FEV1 to be after the surgery, or the functional capacity after the surgery? And that's really important. If somebody might have a good reasonable lung function or FEV1 before the surgery, if we take out the 10 of the segment, then we need to try to calculate what's left. Maybe how they will perform with their left segments. So that's why we calculate predicted post-operative FEV1. Predicted post-op FEV1 is the percentage FEV1. That's normal. Then take the percentage remaining and divide by 100. For example, if the patient is having left lower lobectomy and the preoperative FEV1 17% predicted, left lower lobectomy, 10 segments are taken, 23% of lung is open out. So 70% to start with. So if it is 70% to start with, so 70% of the 70% is 54%. So FEV1 of more than 40% is a low gross rope of PPO. FEV1 of less than 30% is a really high risk group, and it will be difficult to extubate. And between 30 to 40% is intermediate risk, and we can consider DLCO. Next test is DLCO. So they assess the parenchymal function of the lung, and they use carbon monoxide to see the alveoli and going to the blood circulation, and gives a good indication of the gas exchange. So before DLCO, we used to do the blood gases. So PO2 of 60 or CO2 of more than 45 is a cutoff. Diffusing capacity of carbon monoxide corresponds to the functioning surface area of the alveolar capillary interface. So it basically gives the idea of alveolar capillary interface in the lung disease. Sometimes the alveolar capillary interface is damaged chemically, and the gases exchange are poor. So we need to see, have they got enough functioning area to exchange the gases. So number we have to remember is the same as FEV1 of DLCO of 40% or less than 40% associated with increased cardiac and respiratory complication. If it's more than 40%, it's considered to be okay or good. If the DLCO is less than 40%, even if the normal FEV1, they are considered high risk of cardiorespiratory cough, and we have to see other factors like FEV1 functional capacity and the cardiac history, all the other things. If we have a marginal lung patient with ischemic heart disease, hypertension, had a bypass, maybe gets occasional angina, we will probably say no. But if we have a marginal lung patient with no cardiac disease, had an echo or angiogram for some reason, and it's okay, then one can take the chance. So we need to investigate these patients more carefully. So the last point that we are talking about, pre-op DLCO less than 20%, that's pre-operatively, before any surgery, before we have taken out. So have a really high mortality. So in various trials it was proved that it has a very high mortality. So we'll recap the three-legged approach to the respiratory assay. First step is pulmonary mechanics, is to taking the oxygen into the body. Predicted post-operative less than 40% is bad and difficult to be extubated. If the patient have PPO less than 30, it's very difficult to extubate, and they could be stuck in ICU for weeks, all sort of thing. So we need to have a very good reason to operate on the patient who have PPO less than 40 and the mortality is very high. So the next step, oxygen into the alveoli, taking the oxygen. So DLCO less than 40 is the poor gas diagnostic sign. So the gas number is less than 60 and CO2 more than 40. The cardiopulmonary reserve capacity, oxygen carrying from the alveoli into the blood and the rest of the body and the tissue. So the number is 15 mils per kg per minute. Or so the patient can have 3 flights of stairs or 6 meters walk or the exercise. If the patient have FEV1 less than 40%, then we'll see the DLCO. If the DLCO is good, if the functional capacity is good, the patient can be okay. So patient with less than 40% are usually about 25%. So if it's less than 30%, we can't extubate. So the group in between 30 and 40 should be extubated. So they should be comfortable. The patient can benefit from the epidural or the extrapleural catheters, so they will improve the pain management and can have better breathing mechanics and will decrease the risk of atelectasis in these patients. If the predicted FEV1 is greater than 30% and the exercise tolerance and the lung parenchymal functions exceed the risk threshold, then the extubation in the operating room should be possible. Now we'll talk about ventilation perfusion scan. The scan will look at the lung ventilation using a radioactive traces, lung perfusion. Most time this scan is used for the pulmonary embolus, where we see the ventilation perfusion mismatch. We sometimes do the perfusion scan for lung surgery. It's quite useful because sometimes the lung is being taken out, already doesn't have much function, and it is a diseased lung like in tuberculosis, big tumor, big abscess, or whatever the reason. So if we have the perfusion scan, we get the idea of the hypoxic vasic construction, and the lung is not doing very much. If the patient is marginal with FEV1 of 1.5, so it would be absolute contraindication. But if the perfusion scan shows if the lung is contributing to less than 10%, then we will proceed. So we'll exactly know that that lung is contributing 5 or 10%. So it's very helpful in the group of patients who are marginal. So it's good to analyze for the intermediate group of the patients. So this is just a recap. So just to see about the respiratory mechanics. If the predicted post-operative is 40%, we are comfortable. Is 30 to 40%, we consider extubation. and if it is less than 30%, we'll consider stage weaning from the mechanical ventilator, and we have difficulty in extubation and ventilation, and we can probably wean the mechanical ventilation. The tripartite risk assessment model considers the risk of operative mortality in perioperative cardiac events and the postoperative dyspnea. The tripartite risk include the risk assessment of postoperative dyspnea, risk of postoperative cardiac event, and death. So for the dyspnea, we do spirometry, transfer factor, split lung function testing. For the cardiac event, we do AHA, ACA, risk stratification, revised cardiac index. For the death, we do thoracic scores. The address of potentially modifiable risk factors are assessed, and see does the patient accept the risk and the category and a potential impact on the lifestyle. If no, exclude from the surgery. If yes, offer the surgery as a part of multimodality reassessment. The interventions that can be used to decrease the mortality are cessation of smoking, adequate nutrition and rehydration, control of sepsis, and prevent measures of venous thromboembolism and mechanics, Flotron, and correction of the anemia or any other reversible condition, and preoperative optimization by physiotherapy. So these are the risks to control the mortality. So in conclusion, we have to do the history, physical examination, fitness, age, PFT, cardiac status, performance status, operability, diagnosis and staging by PFT, bronchoscopy, CT scan, mediastinal scope, MRI brain and bone scan. Thank you.